Chapter 26, the head, face, eyes, ears, nose, and throat. Slide 1. In this chapter, you will learn about the injuries to the head, face, ears, nose, and throat. Please use this presentation to guide you in your textbook reading. Slide 2. Prevention of injuries to the head, face, eyes, ears, nose, and throat are addressed through the use of proper head and face gear and educating the athlete. Education includes the proper techniques for initiating contact and the danger of concussive brain injury and second impact syndrome that are common topics in sports medicine today. Slide 3. The skull is comprised of 22 bones, and except for the jaw, are joined together by immovable joints called sutures. The cranial vault houses the brain and provides protection and support. The scalp is the covering of the bone and is rich in blood supply, which explains why scalp lacerations bleed excessively. The brain is divided into 4 sections. The cerebrum is the largest part of the brain and is referred to as the cortex. All voluntary muscle activities and interpretation of sensory impulses and controlling of higher mental functions originate here. The cerebellum controls the movements of the motor muscle and coordinates voluntary muscle movements. The pons control sleep, posture, respiration, swallowing, and functions of the bladder. The medulla oblongata is the lowest part of the brainstem and regulates the heart rate, breathing, blood pressure, coughing, sneezing, and vomiting. The meninges are 3 membranes that protect the brain and spinal cord. Within the meninges is the cerebrospinal fluid that provides buoyancy to the brain and diminishes the transmission of shocking forces. Slide 4. The assessment of head injuries is very comprehensive and requires both initial and ongoing attention. Head trauma results in more fatalities than any other sports injury. A direct or indirect blow, which occurs when the head is violently snapped, can cause a mild traumatic brain injury. This is the cause of concussions. Concussions may result in unconsciousness, although the majority of concussions sustained by athletes do not involve a loss of consciousness. Disorientation, memory loss, lack of coordination or balance, and cognitive deficits are also present. On-the-field management of the unconscious student-athlete was previously discussed in the course related to on-the-field management. Refer to this section again as needed. The following assessment pertains to the conscious athlete who sustains a head injury. History involves asking questions relating to the mechanism of injury, locating painful sites while checking for cognitive function. Sometimes the athlete will display untypical emotions after a head injury with excessive crying, questions, or other outbursts. Don't be surprised by this. Instead, realize it is a sign of concussion. Slide 5 and 6. During the observation phase, assess for cognitive and motor functions. Refer to these slides for a thorough list. Slide 7. The mechanism of injury for the head is the same as the mechanism of injury for the spine. Therefore, you must palpate for injury in both areas. Identify areas of point tenderness, deformity, swelling, and bleeding. Look also for a straw-colored fluid coming from the ears or nose, which indicates a skull fracture. Slide 8. There are numerous special tests used to evaluate eye function, balance, coordination, and cognitive ability. Refer to the textbook for a complete description. Slide 9. Skull fractures occur from blunt trauma, such as a baseball or shot put to the head or a fall from a height. The fracture is not the primary concern, but rather the potential trauma that was caused to the brain. The signs and symptoms include pain, headache, nausea, fluid in the ear or nose, ecchymosis around the eyes, referred to as raccoon eyes, or behind the ear, referred to as battle sign. Treatment consists of immediately hospitalizing and referring the student-athlete to a neurosurgeon for evaluation and possible surgical intervention. Slide 10. Cerebral concussions, which is a form of mild traumatic brain injury, occurs from a direct or indirect injury. The assessment should include clinical symptoms, physical signs, behavioral changes, cognitive impairment, and sleep disturbance. Current research states, and I quote, "The most logical approach is to determine the severity of the concussion based on the presence and overall duration of symptoms only after all concussion signs and symptoms have resolved." End of quote. No longer is a loss of consciousness the primary component of assessment. If an athlete loses consciousness, he or she must be removed from competition immediately and evaluated by an MD before returning to play. Post-concussion syndrome is a complication from concussion and results in a chronic headache, impaired memory and concentration, anxiety, irritability, fatigue, depression, and visual disturbances. Slide 11. Epidural and subdural hematomas occur when an artery or vein in the brain is damaged, causing excessive bleeding and increased pressure in the brain. In an epidural hematoma, the student-athlete loses consciousness and quickly deteriorates with decreased blood pressure and pulse. Immediate medical intervention is needed to surgically relieve the hematoma from the brain to avoid permanent disability or death. Slide 12. Subdural hematomas occur more frequently in athletics and is the primary cause of death. The dura mater and vessels are torn from extreme acceleration and deceleration forces to the brain. Symptoms include a possible loss of consciousness, dilation of one pupil, headache, dizziness, nausea, or sleepiness. Immediate medical attention is needed to treat the hemorrhaging. Slide 13. The face includes the supraorbital ridges, which houses the frontal sinuses. The maxillary bone supports the nose and passages, and the mandible is the jaw, which supports the teeth, the larynx, trachea, upper airway, and upper digestive tract. The TMJ is the articulation between the mandibular condyle and the fossa of the temporal bone. In layman's terms, it is the jaw joint. Slide 14. Fractures of the mandible, the lower jaw, occur in collision sports. Notice the relatively little padding and sharp contours of your jaw. The most frequently fractured area is near the jaw's frontal angle. Refer to the pictures in the presentation and textbook. The signs and symptoms include pain, deformity, and the inability of finding the normal bite with the upper and lower teeth. Bleeding around the teeth and numbness to the lower lip is also present. Refer the athlete to a physician. Reduction and fixation of the jaw by a physician is included. Recovery time is 4 to 6 weeks, with return to activity in 2 to 3 months using protective headgear and mouth guard. Slide 15. The jaw is prone to dislocation because of the inequity in size between the mandibular condyle and temporal fossa. This occurs with blows to the open mouth. It can include a luxation, which is a complete dislocation, or a subluxation, which is a partial dislocation. Apply a large ice pack and refer the athlete to a physician for reduction. The athlete can resume activity in approximately 7 to 10 days. Slide 16. A zygomatic fracture is a cheekbone fracture which occurs when a substantial blow to the cheek, such as in baseball when the player slides into second base and the opponent's knee strikes the cheek. There will be obvious deformity to the cheek and possibly to the eye. Implement your emergency action plan, apply ice, and treat for shock. Surgery is a possibility to reduce the fracture and realign the sinuses and orbit of the eye. Healing requires 6 to 8 weeks, followed by protective gear upon return to activity. Slide 17. This next slide is graphic, so please proceed with caution. Facial lacerations are common in sport, and substantial bleeding is often included. Cover the injury with direct pressure and refer the individual to a physician. If shock or excessive bleeding is present, implement your emergency action plan. Slide 18. Teeth injuries include fractures, partial, complete dislocations, and loosening from direct blows. Fractured teeth cannot be salvaged. The individual may experience nerve pain when air or cold water comes in contact with the tooth. Partial dislocations means that the tooth is not fractured, but is very loose and has relocated to a different position. Complete luxations refer to teeth that have been completely removed from the socket. Slide 19. For fractured teeth, refer the athlete to their dentist for further treatment. The athlete may continue participation as tolerated. For subluxed teeth that are loose but still intact, refer the athlete immediately to his or her dentist for evaluation and treatment. For dislocated teeth, locate the tooth and preserve it in one of the following ways. First, put it in a glass of water. Second, insert the tooth back into the socket and have the athlete hold it in place while en route to the dentist. Or third, have the athlete secure it under their tongue or along their cheek. Slide 20. The treatment for dislocated teeth is reimplantation, followed by stabilization. In many cases, the tooth will successfully and permanently reimplant. In other cases, the tooth will not be salvageable and the individual will undergo advanced treatment. A fractured nose is the most common injury to the face. It may cause a simple or complex fracture. The picture demonstrates a complex fracture. Pain, nosebleed, and deformity is present. There may be crepitus or grinding with palpation. Control the bleeding and refer the patient to a physician for X-ray and reduction. Simple and uncomplicated fractures will not prevent athletic participation. However, complicated fractures require surgical intervention to correct the malalignment and prevent sinus blockage. Slide 22. Epistaxis is nosebleed that occurs from a direct blow or oftentimes from nose picking. Direct pressure, leaning forward, applying ice, and pressing the soft tissue just above the lip are treatment protocols. Athletes sometimes insert gauze or tampons in a bleeding nostril so that they can continue athletic participation. This practice is not recommended because it introduces infection into the sinuses. Slide 23. Cauliflower ear occurs in boxing, rugby, and wrestling when the athlete does not wear appropriate protective headgear. The compression and shearing force permanently alters the cartilage of the ear. Symptoms include an initial hematoma, followed by a thickening and deformity of the cartilage. Sometimes the deformity inhibits normal hearing. It is imperative to prevent this disfiguring condition by wearing appropriate headgear and using anti-friction agents such as petroleum jelly. Acute hematomas can be drained to prevent a chronic condition from occurring. Slide 24. Swimmer's ear is an infection of the ear canal from excessive wetness. My pediatrician explained it well in this way. When your hands are immersed in water for an extended period of time, the results are a very wrinkled, waterlogged skin. This is what happens to the ear canal from excessive water. Tiny cracks then occur in the ear canal, which introduces the area to infection. If you pull down on the earlobe and it increases pain, this is a positive sign for swimmer's ear. Prevention is important by properly drying the canal after swimming activities. This can be accomplished through a mixture of alcohol and water or using over-the-counter drying agents. Antibiotic eardrops may be needed for athletes whose swimmer's ear does not heal on its own. Slide 25. An orbital hematoma is a black eye. It is caused from direct blows to the eye and can also cause subconjunctival hemorrhage as seen in the picture. Management consists of ice with rest if distorted vision is present. Because of an increase in orbital pressure, those who sustain an eye injury should not forcibly blow their nose. This would increase hemorrhaging. Slide 26. Foreign bodies in the eye can cause simple and temporary irritation or a more complex problem. Initially, the eye will be watery and red in an attempt of the body to flush out the object. No attempt should be made to remove the foreign object by rubbing because of the potential of scratching the cornea. Closing the eye until the initial pain subsides is the first recommendation. Various techniques of pulling down the upper or lower eyelid are included in the textbook. Once the object is removed, the eye should be cleaned with water. If the object embeds in the eye, the individual should be referred to a physician for removal. Slide 27. If the eye continues to be irritated, red, watery, or photophobic, then a corneal abrasion may be present. The doctor will place a fluorescein strip to the abraded area and evaluate the eye under the light. Abrasions will be outlined as green. The eye will then be given antibiotic drops and patched if needed. Slide 28. A blow to the eye can also cause retinal detachment. The detachment is painless and symptoms include seeing specks floating before the eyes, flashes of light, or blurred vision. Sometimes the individual states that there is a curtain falling over their field of vision. The individual should be referred immediately to an ophthalmologist for evaluation and treatment. Slide 29. Acute conjunctivitis, also referred to as pink eye, is a highly contagious bacterial infection that can quickly spread through an entire team or physical education class. The individual will complain of pain in the eye, tearing, redness, and swelling. Sometimes itching and burning are present. Refer the athlete to a physician for evaluation and antibiotic treatment. Be sure your athletes and students do not share towels, and they also must engage in proper hand washing to prevent the spread of pink eye. Slide 30. Throat contusions are rare but dangerous. Clotheslining is a type of trauma where the athlete is struck in the throat by another player's outstretched arm. Such a force can cause damage to the carotid artery. The athlete may experience pain spasmodic coughing, a hoarse voice, and experience difficulty in swallowing. He or she may also have difficulty in breathing. Fractures of the throat cartilage are rare, but will demonstrate as extreme difficulty to breathe with frothy blood coming from the mouth. Treatment consists of protecting the airway and monitoring symptoms. Cold should be applied. Any signs of increased swelling or difficulty breathing warrants immediate referral to a physician and the implementation of your emergency action plan.